Thanks, Chair. It's always an honor and pleasure to be here in PKC. Thanks, Sachin and Parag. So, fixed bearing or mobile bearing or middle pivot. Basically, there are three different philosophies. In fixed bearing knee, what you do, the polyethylene is fixed to the tibial base plate with some kind of locking mechanism. In mobile bearing, it rotates around on the tibial platform. Whereas in medial pivot knee, there's a different curvature, radius of curvature, whereas the medial side is more conforming compared to lateral side, which is more flat and flat design. So before that, one must understand the kinematics of normal knee. There is a posterior rollback mechanism. The femur is a circular, surface which moves on the flat surface like tibia. So when the knee flexes, there's a possibility of femur may dislocate, and hence the posterior cruciate ligament behind pulls back the femur, what is known as rollback mechanism. To do this, there is an internal rotation of the tibia. The axis of rotation of this internal rotation passes through the medial compartment. So in a fixed bearing knee, in order to achieve this, to optimize the knee kinematics, in order to achieve this rotation, that requires a low tibiofemoral articular conformity to optimize this. And that increases the stresses on the polyethylene. There's a material fatigue and pitting, and hence it may lead to loosening. That was the earlier concept, because in earlier designs, no implant has got a clearly superior locking mechanism between the polyethylene and the tibial base plate, and that is one area of implant design that has never been tested stringently earlier. Of course, the newer design have got a better locking mechanism, leading to less of wear. And hence, mobile bearing knee came into picture, which permitted around 8 degrees of rotation. So because of this rotation, the normal mechanics were restored. So this is a PFC, rotating platform. I do commonly rotating platform knees because it's technically little easier, because you don't have to lock the polyethylene, you have to just insert the polyethylene. And on the other hand, it's a little bit more forgiving, because you can put the tibial component giving adequate bone coverage, even if little bit of less of external rotation is permitted, because the polyethylene is rotating. Moreover, isolated femoral stem extender, whenever it is required in special situations like supracondylar fracture with arthritic knee, there I prefer to use a rotating platform, because it puts less stress on the polyethylene, or else in other designs and fixed bearing, you have to put a tibial stem extender. Moreover, on the other hand, whenever you require a tibial stem extender, for example, when there is a stress fracture or fracture of the tibia, or when there is a defect on when there is a building of the tibial defect, then you need to put a tibial stem extender. There you need to put a fixed bearing knee, or else you have to use a revision type of component with a tibial stem extender in a rotating platform knee, which is more expensive for our the patients. So you need to achieve a good, ligament balancing both in flexion and extension. But if you are unable to achieve a very good ligament balancing or leaving a trapezoidal gap, there is a possibility of, rotating platform. The polyethylene may spin up. That is one of the disadvantages of the rotating platform knee. Having said all that, you see that 20% of patients are dissatisfied after total knee replacement. Though we check the, your stability in full extension and 90 degree after knee flexion, but there is a possibility of mid flexion instability in 60 degree and 40 degree of knee flexion. And especially the patients are dissatisfied when getting up of the front chair or while getting down the staircases. Since the medial pivot knee which came into picture, though the conventional knee you see more or less there's a tibiofemoral conformity which allows some kind of rotation. In a medial pivot knee on the medial side, the tibiofemoral part is more conforming compared to the lateral side where it is less conforming or flat on flat design. And this allows the medial pivot, the rotation takes place, and that prevents the paradoxical anterior rollback mechanism which happens in the, your fixed bearing knees. So flexion gap balance is done first, and hence there is a better flexion stability. It mimics more natural knee kinematics, and the reported survival rate is about 99% at the end of 17 years. When size is a concern, especially short Asian females, these are the sizes which can use this mobile bearing knee which has got a very smaller size which fits into our small Asian females compared to other designs of the knee which are available in the market. So what I prefer mobile bearing knee in most of the cases because I achieve a good ligament balancing, I can adjust the tibial component placement that is little less, more forgiving in a rotating platform knee. And when I use a only femoral stem extender in specialized cases, I prefer a rotating platform knee. It is technically a bit little easier and I get excellent range of movement. Whereas on the other hand, if I am unable to achieve a proper ligament balance, especially in difficult knees, I prefer a fixed bearing knee. And whenever I need a tibial stem extender, I prefer a fixed bearing knee, especially when there is presence of bone defects, where I build up the bone defects. Whenever there is a thin polyethylene like 8 millimeter fixed bearing knee is an option, especially in osteoporotic bones and in obese patients, because the post of the fixed bearing knee little longer compared to rotating platform knee. Whenever you expect a greater flexion instability, especially big flexion deformities, probably medial pivot knee is preferable, which I usually never use. I thank you for a patient hearing, and thanks Sachin and Parag again for giving me this opportunity.